Today we're going to be talking about electrocardiogram correlation to cardiac events. So the electrocardiogram, we're going to start there with that and what exactly that is. So the heart's electrical activity is transmitted outward towards the body's surface. Electrodes can be placed on the surface of the skin, which will allow the activity to be recorded and evaluated. So what the electrocardiogram is it's a graphic recording from the body surface of the electrical currents that are generated from the heart. Down in the right-hand corner here, I have an example of what an electrocardiogram would look like. This is a pretty normal electrocardiogram. And then we're going to get into kind of what the different sections are. So complex and waves are two of the ways you can describe parts of the ECG. So the QRS complex is what indicates ventricular depolarization and the contraction of the ventricle. The T wave represents ventricular repolarization. So this is always going to follow the QRS because it's following the depolarization. If you have a QRS, you must have a T. It's usually going to be small and rounded, but it can be nearly flat in some leads that do make it difficult to identify. And then you have the P wave. This is going to be the first wave that's actually seen in an ECG. This indicates atrial depolarization and contraction. It's going to be rounded. It's going to be much smaller than the QRS, usually smaller than the T. It can be uprighted, inverted, or notch. It is going to occur before the QRS normally. It can occur during or after. That would kind of be if the heart is not following the normal conduction of starting in the atrium and then heading to the ventricles. Some rhythms may have more than one P wave or have none at all, depending on where the heartbeat is originating from. So if you notice, the QRS complex was the depolarization, and then you could see the repolarization. However, with the atria, we don't see the repolarization, and that's because it's going to be happening around the same time as the ventricle depolarization. And because of how large that QRS complex is, that atrial repolarization kind of gets hidden. The ECG can also be broken up into segments and intervals. So a segment is a piece of baseline. So baseline is the flat line that you have for the ECG that all of your waves kind of come off of. So it's going to be a piece of the baseline that connects two waves. So you have the ST segment. That's the end of the QRS to the beginning of the T, and that we're going to refer to later when we talk about specific ECGs correlating to certain cardiac events. And this is going to be the time between ventricular depolarization and the beginning of repolarization. And then you also have what's called an interval. So this is going to contain at least one wave and one segment within an interval. So you have the PR interval, which is the amount of time the signal takes to travel through the atria, AV node, bundle of His, and the bundle branches. And its length shows how much time the ventricles have to fill before contracting. And then you have the QT interval, which represents the total ventricular activity, how long the ventricles take to depolarize and then repolarize. So rhythm initiation speed, I kind of was touching on this before when I was talking about that P wave. So this is where the heartbeat is originating from. So it should always be originating from the sinus node, but sometimes that is not always the case. It could also be originating from the atria. This is called an atrial rhythm. So either the atrium, but not the sinus node of the atrium. And it's going to be individual beats that may interrupt another rhythm. Junctional or nodal, so that's going to be coming from the AV node, or ventricular rhythm initiation, which is going to be coming from the ventricles. You also have a different speed of heart rate. These are just different ways to describe someone's heart rate. You might be familiar with the terms bradycardia and tachycardia. Brady is a slow rhythm. Idio is normal or intrinsic. Accelerated is somewhat faster than normal. And then tachy would be abnormally fast, which it would have to be over 100 beats per minute to be considered tachycardia. So tachycardia, here's an example of what ventricular tachycardia would be. So without a pacemaker from a higher level. So this is a lot of times caused because the initiation of the beat is coming from within that ventricle instead of from that SA node. So the ventricular tissue is going to generate its own signal because it does need to continue beating so that the patient or the individual can stay alive. This is going to be irregular electrical signals though in the lower chamber. And this ventricular tachycardia, so it's ventricularly triggered, but it's also a very high heart rate. The ECG for this is going to be very broad. It doesn't have those nice sharp spikes that we normally see. And it's just going to be a QS. You're not visualizing that R from the QRS complex. So because it's happening so fast and the ventricle keeps firing and trying to contract, the ventricle is actually unable to completely fill and empty, which will end up creating an oxygen deficiency to the rest of the body. This can end up resulting in fainting or loss of consciousness for the person. It can also cause cardiac arrest or sudden death if it's not corrected. Next, we have heart block. So heart block is when there's going to be a disruption coming from the SA node down to the ventricles somewhere. So they kind of classify these in different degrees. So a first degree heart block would be that there's just a slow conduction through the AV node. So what this is going to look like on the ECG, your PR interval is going to be greater than 0.2. So each of these intervals should be a certain time frame that shows a normal beating heart. Since the conduction is slow, that interval between the P and the R is going to start to lengthen. And then that brings us to second degree. So with this, you have some intermittent blocking. So it's going to be increasingly longer PR intervals with each beat. As you can kind of see, that interval is lengthening between these beats, leading up until a point where it gets to a missed beat. So you're actually end up dropping a beat because of that conduction. And then you have second degree type 2, which is intermittent blocking as well. This is going to give a constant PR interval until a beat is dropped, but you also might start to see more beats dropped within that time. So you have the second degree AV block, 2 examples of that listed on the right side here. And then you have third degree. So this is a complete block from the atria to the ventricles. So the origination is not getting to the ventricles, which means the ventricles are going to have to start triggering that contraction itself. So the beat is originating in the ventricles. Now, for a beat to originate in the ventricles, this oftentimes is a slower, more irregular beat. So for this one, you're going to notice that those heartbeats are spread much farther apart and the heart is beating much slower. Then we have bundle branch block. So in the bottom right, you have an image of a heart, and it is showing the conduction system up from the sinus node, which is where each contraction should be originating from, travels down to the AV node, and then it travels down to the ventricles, where it splits into either the left bundle branch or the right bundle branch, depending on which ventricle it needs to trigger next. So when you have a bundle branch block, either the right or the left has a blockage. So although it is being triggered from the sinus node still and making its way to the ventricles, once it gets to the ventricles, there's a blockage there. So it could be either right or left, depending on where the block is located. The QRS is going to look notched when this is the case, or rabbit ears. So if it's a left bundle branch block, it's going to be a normal QRS it's going to be going up and have a notch. If it's a right bundle branch block, it's going to be inverted and have that notch in it. And examples of those are on the left side of the screen there. All right, and then that brings us to a STEMI versus a non-STEMI. So STEMI is what is more commonly known as a heart attack when someone says that someone has a heart attack. So this is a extensive heart damage. There's a total blockage. The blood is not getting through the coronary arteries to be able to deliver blood and oxygen to the sections of the heart. An NSTEMI or non-STEMI would be an intermediate form. This is causing less extensive damage to the heart, but it is when there's enough buildup that it is decreasing the blood flow to those areas. And STEMI stands for ST elevation myocardial infarction. So examples of what those QRS or of what those ECGs would look like are located on the left here. So a normal ECG is seen first, a STEMI. So again, remember I said earlier that ST segment, this is where that comes into play here. So normally that ST segment should be kind of flat where it's, between the S from the QRS and the T wave where we are repolarizing. So this is going to be elevated. It's not that nice baseline. With a STEMI, it's actually elevated, and certain sizes of that elevation also are taken into account when they're trying to see how severe the STEMI is. So a non-STEMI though, which is kind of that ischemia that we're talking about where it's less blood flow, is going to be a depression. So with a STEMI, it's going to be an ST elevation. With a non-STEMI, it's going to be an ST depression, or a T inversion can also be seen with that one as well. All right, so and then, what's the importance of ECGs and being able to read these? So ECGs are a very nice non-invasive diagnostic modality for being able to investigate the severity of cardiovascular diseases. So this is a way for us to kind of get a quick look at what's happening inside that heart without having to go into a cath lab, without having to get into these lengthy, costly diagnostic imaging procedures. You can hook someone up to an ECG and look at what is going on with that, the electrical impulses within the heart. It's also nice because it monitors patients on antiarrhythmics and other drugs. It's used for a preoperative assessment and for screenings. And also because cardiovascular disease is the #1 cause of death. So that definitely puts great emphasis on healthcare providers developing the skills and the knowledge and being able to interpret ECGs to be able to provide the best care and promptly. Many healthcare providers do find the advanced interpretation of ECGs a complicated task, especially when errors in the analysis can lead to misdiagnosis or delaying the appropriate treatment that is needed by the patient. So being able to identify what kind of correlations to specific cardiac events you would see on ECGs might end up being the difference between someone living and someone dying. And then these were the references that were used for this presentation. Thank you.